Hi everyone, it looks like people are coming into the room. Great, we might make a start. We've got quite a bit to cover. So before we begin, I'd like to acknowledge that I'm presenting this webinar from the lands of the Yorta Yorta people. I acknowledge the traditional custodians of the various lands on which you all work today and all the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present and emerging. Thank you for registering to attend this webinar or to those that may be watching the recorded version at a time that suits. The webinar has been developed for medical professionals who are wanting to understand the details of this project. My name is Josie Thomas and I'm the project manager at the National Transport Commission for this project. I'm also joined by Michael McCarthy, who's our Strategic Engagement Advisor, Liam McElveen, who's our Policy and Project Officer, and Fiona Langren, who's from Project Health, who's our consultant and has an extensive history with advising on assessing fitness to drive. Looks like we've had a good turnout today for those who regularly perform road and rail health assessments. Here's an overview of the structure for today's webinar. Fiona and I will co-present on the following topics and then open to questions. The structure resembles the outline of the discussion paper, but of course we don't have time to go into detail today, so we recommend going back to the discussion paper if you'd like to read up on something in more detail. The discussion paper also isn't a literature review, but it does paint a picture of the health issues impacting the industry, outlines the legislative and policy frameworks, and also some other initiatives that we're aware of. We're seeking your expertise to understand how possible solutions might work in reality. And we don't have a lot of time today to go into lengthy discussions, but we can meet you outside of this to have further chats. Please add your questions to the chat if anything comes to mind during the presentation. Otherwise, we'll let you raise your hand and unmute at the end for questions. So firstly, some important project background and context. In 2022, Transport Ministers asked the NTC to identify options to improve the approach to screening and diagnosis of sleep apnea, diabetes, and cardiac risk levels in heavy vehicle drivers. The catalyst for this request was a chief coroner's finding relating to the death of a 4-year-old child involving a heavy vehicle driver with undiagnosed sleep apnea. We released a discussion paper in March and are consulting on possible options until Friday, the 9th of May. We've included a terminology section in the paper to describe that while the IDEM request relates specifically to heavy vehicle drivers, a range of other commercial vehicle drivers experience similar health-related issues and are managed within the current systems, including licensing and accreditation. These include public passenger drivers, such as buses, taxis, rideshare, as well as dangerous goods drivers and driving instructors. The scope of the project includes commercial vehicle drivers that have the commercial standards applied to them via assessing fitness to drive, and we're wanting to test this during consultation. From the outset, I want to clarify that any changes to the screening criteria will be applied by licensing and accreditation schemes within their current frameworks. This means that if drivers aren't currently required to have a health assessment, this won't change. We'll discuss these options in more detail at the end of the presentation, but I thought I'd flag the 3 options here for you to keep in mind as we go through the content. The options represent a staged approach and go from option A, no change, to option B, improving implementation of current AFTD guidance, to option C, which includes the 3 sub-options for screening for the 3 areas. We won't be recommending regulatory change to individual driver licensing regulation around timing and frequency of health assessments. We will be improving screening for those who are currently assessed periodically for licensing purposes, for example in the ACT, as well as for accreditation purposes. This project focuses on screening and management for drivers found at risk. It will not be looking at developing or revising the guidelines for how medical conditions are managed once they're diagnosed. This will be considered as part of the next review of assessing fitness to drive. Here's a timeline with our 5-phased approach. We're currently in phase 4 and 8 weeks of public consultation. We'll submit recommendations to ministers in the middle of the year. There's currently no date for a ministerial meeting locked in yet due to the upcoming federal election. The project objectives include investigating the current state of the issues, formulating evidence-based options in consultation with stakeholders, and undertaking extensive stakeholder consultation to establish recommendations, which we're doing now. This diagram shows our key stakeholders. We have a heavy vehicle health advisory group, which includes government agencies, driver licensing authorities, heavy vehicle industry, heavy vehicle regulator, commercial vehicle industry and regulators, unions, and medical professionals. We've also established 3 working groups on sleep disorders, cardiovascular conditions, and diabetes. And we have medical professionals and specialists from the Cardiac Society, Heart Foundation, Diabetes Society, Diabetes Australia, Australasian Sleep Association, and the Institute for Breathing and Sleep. We've got Andrew Lingwood on the call today, and he's been across all the working groups and our advisory group. He's representing ANSOM, who will also provide a joint submission to the review. We've convened these groups once last year and have been in touch regularly via phone and email to consult and progress the contents in the discussion paper. This shows our consultation plan. The blue activities that we've undertaken and the yellow is the future activities. Over the next 6 weeks, we'll be hosting webinars such as this, one-on-one online meetings, face-to-face sessions with stakeholders, and we'll also be running a short workshop at the ATA conference at the end of the month. We've developed a comprehensive communications and engagement plan and worked in partnership with stakeholders to identify channels to get the key messages out to industry. We're really keen to understand the views from a policy, operational, and medical perspective and discuss how these changes might impact your organisation, stakeholders, members, or patients. Before we get into the detail, I thought it was important to highlight what Assessing Fitness to Drive, or AFTD, is. AFTD sets out medical criteria for licensing decisions in Australia and provides guidance regarding how drivers with various conditions should be assessed and managed. It's different to the rail standard, if that's what you're familiar with, as that's a fitness for duty standard. AFTD includes criteria for both private and commercial drivers. The focus of this project is on commercial vehicle drivers. The diagram here shows all the different licence classes and which standard applies. AFTD is also used for heavy vehicle accreditation programs and accreditation for public passenger vehicle drivers, dangerous goods drivers, and driving instructors. The NTC reviews AFTD every 3 years, and Austroads implements the standards. The next review is due to commence later this year once we wrap up this commercial vehicle project. Many people think that AFTD is the overarching document that guides the national approach to managing fitness to drive. This is true to some extent, as it does include important medical criteria. But really, it's the state and territory licensing and road safety legislation which sets the requirements around frequency and reporting requirements, and these vary between jurisdictions. We've developed this diagram to illustrate the complex relationship of licensing, other accreditation schemes, and how they relate to AFTD. While AFTD includes information about reporting requirements, such as driver and health professional reporting obligations, these are determined by legislation, not by AFTD. I want to emphasise that these requirements vary between jurisdictions and are not affected by this current project. In Appendix 1 of AFTD, it includes information about when and how often health assessments are required for various licence types, as well as for accreditation programs. These too are determined by state and territory legislation and are not affected by this current project. The appendix currently doesn't include requirements for accreditation programs, but these might be included in the future. I hope that that provides some important context around the relationship between licensing and accreditation and its impact on AFTD. Although we're not proposing any changes to the frequency and timing of health assessments, I thought I'd include this table to highlight the varied approaches different jurisdictions have adopted. As you can see at the top, ACT is the only jurisdiction that has initial and periodic health assessments for heavy vehicle licence holders. These are 5-yearly for MR licence holders and above, and this has been a recent change. There's further information in the paper about this. South Australia, New South Wales, Queensland and WA have annual age-based assessments for all driver classes, commencing at 70 for South Australia, 75 for New South Wales and Queensland, and 80 for WA. These assessments include heavy vehicle licence holders. There are some specific requirements in some states to target high-risk drivers. For example, in New South Wales, health assessments are only required for drivers of MC vehicles, and these are required on initial application and then periodically depending on age. Tasmania requires assessment at initial application only for MC, and ongoing assessments aren't required for these drivers. In all states and territories, more frequent assessments are required if there's a medical condition that may impact fitness to drive as per the AFTD standards. This table explains the health assessment requirements for various public passenger accreditation and heavy vehicle accreditation. The timing and frequency varies, but the health assessments and medical criteria are all based on AFTD. The changes being proposed under this project will impact these drivers. However, as they're already having regular health assessments, it's unlikely to impose a significant burden, although the management of drivers found to be at high risk will be an important consideration, and we'll be exploring that in consultation. The costs and benefits will also be discussed a little bit later. This slide includes some key information on the heavy vehicle industry. It's important to note that light rigid drivers, LR, are not assessed according to the commercial vehicle standard unless they fall under accreditation programs such as public passenger, etc. In 2024, there were over 2.2 million licensed heavy vehicle drivers in Australia, with truck driving being one of the most common occupations among Australian males. However, only about 10% of these represent professional truck and bus drivers. As of May 2024, there were over 180,000 truck drivers with a median age of 47 years, compared with 39 years for other occupations. And there were over 37,000 bus and coach drivers with a median age of 58 years. These stats show that the heavy vehicle industry is an ageing industry that is also heavily male-dominated. We know that increased age and male gender can increase the likelihood of some medical conditions. This slide includes some key information on road safety data for 2023 to 2024, and we've broken into deaths and injuries. During this period, 176 people died in crashes involving heavy vehicles and 15 involving buses. Fatal crashes involving heavy trucks and buses cost the economy about $980 million per year. In terms of injuries, about 500 truck occupants are hospitalised from road crashes, as well as 250 bus occupants per year. Of the heavy truck occupants, 30% are categorised with high threat to life injuries. These statistics highlight the importance of getting the policy settings right to manage health and improve road safety outcomes. Now looking at the broader commercial vehicle industry, it's quite diverse and includes around 419,000 accredited drivers, although this may include an overlap as drivers can be enrolled across multiple schemes. Over 100,000 taxi and rideshare drivers, over 26,000 dangerous goods drivers, 5,034 Western Australian Heavy Vehicle Accreditation Scheme operators, 3,149 Basic Fatigue Management operators, 101 Advanced Fatigue Management operators, and 183 truck-safe operators. It's well established that compared with the general population, heavy vehicle drivers, including truck drivers and bus drivers, are at a higher risk of a raft of health conditions, including heart disease, diabetes, sleep apnea, poor mental health, poor musculoskeletal health, and drug and alcohol use. The Monash University Driving Health Study included surveys and phone interviews with over 2,000 truck drivers. It included self-reported data along with workers' compensation data. At a high level, the study indicates that 5.3% said they had cardiovascular disease. Research suggests that cardiovascular disease is the most common cause of death of drivers. Cardiovascular disease accounted for 26.67% of death benefit claims for male members of the Transport Workers Union between 2004 and 2017. 8.2% reported having diabetes, and 13.4% reported having diagnosed sleep apnea. Over 80% of truck drivers were overweight or obese, which is higher than the Australian average for males. 25.8% reported having high blood pressure. We know that obesity is linked with other health conditions such as type 2 diabetes, high blood pressure, stroke, and sleep disorders, which are the focus of our project. Based on our research, we recognise that these self-reported rates are below those in the general community, pointing to potential benefits of improved screening. It's also interesting to note that almost a third of drivers had 3 or more diagnosed medical conditions, which is 4 times greater than the Australian average. Research has suggested that having 3 or more chronic conditions nearly doubles the odds of experiencing a crash. This statistic is particularly concerning from a road safety point of view and highlights why we are taking a holistic approach and considering the 3 conditions in this project. You can review some of the other studies in more detail in the discussion paper. As specialists in the medical profession, we're interested to understand whether you're aware of any other studies that could point us to better understanding of priority health areas for commercial vehicle drivers. I'll now hand over to Fiona to take you through the current state of screening for the 3 conditions.
Thanks, Josie, and thanks everyone for attending today. I hope it makes it clearer about what we're after and maybe prompts you to think about how this project might affect what you do in assessing commercial vehicle drivers. So as Josie explained, the project focuses on 3 high-risk conditions identified by the Transport Ministers. And these are conditions that, based on the research that Josie has just presented, appear to be common among heavy vehicle drivers as well as other commercial vehicle drivers. The discussion paper acknowledges that there are a broader range of health issues affecting commercial vehicle drivers, and you'll see that in some of the driving health data. But in the first instance, we're focusing on identifying screening options for these 3 conditions. Also, in considering the approach to screening, we've been mindful that there is overlap of these conditions and that they have they share common risk factors. This slide highlights this, which shows the risk factors that are included in common screening tools for cardiovascular disease, diabetes, and obstructive sleep apnea. So while we're presenting screening approaches for individual conditions, it's the intention for the guidance in AFTD will take the overlap and integration needs into account for these conditions, and that we'll work towards, depending on which option is recommended, we'll look at developing the guidance in AFTD accordingly. So our overall goal of introducing screening and the goal outlined by the ministers is to enable early identification and management of these conditions and their respective risk factors, thus reducing safety risks as well as improving commercial vehicle driver health outcomes and career longevity for this important industry. Next slide, thanks Josie. So I'm just going to run through the issues we've considered so far in addressing the screening for these conditions. This reflects the input from the 3 working groups as well as input from other stakeholders. And so aligning with the overall goal, the goal of introducing cardiovascular risk screening is to enable early identification and management of cardiac risk for commercial vehicle drivers, although we acknowledge that not all cardiac events can be predicted or prevented. Currently, AFTD does not prescribe cardiovascular risk screening. However, it does advise in the text that it's good practice for health professionals to give consideration to overall risk if drivers are found to have risk factors. So you'll see this guidance on page 64 of AFTD. It suggests calculating the cardiovascular disease risk score. It might provide helpful information for determining fitness to drive, especially for commercial vehicle drivers. The advice is not currently reflected in the forms that are hosted on the Austroads website, so we expect that cardiovascular disease risk is unlikely to be considered routinely in the assessment of fitness to drive of commercial vehicle drivers. In considering possible approaches for screening, we looked, both the team and the cardiovascular disease working group considered approaches in international jurisdictions such as Canada, US and the UK. And none of these jurisdictions prescribe CVD screening, but there has been support from the American College of Cardiology and the American Heart Association for adopting a screening approach similar to our cardiovascular risk calculator. The rail standard has provided a further reference point for this project, and ministers and other stakeholders have identified this as a potential model for the commercial vehicle industry, acknowledging the differences between these transport systems. The rail standard, as many of you would know, has included predictive cardiovascular risk screening since its inception, based on the recommendations from the Waterfall Inquiry. And the current standard incorporates the cardiovascular risk calculator that was updated in 2023. The standard includes specific criteria for managing fitness for duty depending on the cardiovascular risk strategy category. This would not be intended to be criteria for fitness to drive, so that's likely to be an important difference, which we'll explore during the consultation. We also looked at population screening recommendations, and we had a representative from the College of GPs on each of the working groups, and particularly looked at the RACGP Red Book in that regard, and in line that the Red Book aligns with the CVD risk calculator recommendations for screening every 5 years for people between 45 and 79 without known cardiovascular disease. Okay, the next slide briefly highlights, again, you'll all be familiar with now with the new cardiovascular risk calculator as well as the older versions, and that the data inputs are a series of risk factors, and in this new version there's a number of reclassification factors which enable a more refined view of the risk. It also, so those sorts of modification factors include family history of early death associated with cardiovascular disease, ethnicity including Aboriginal and Torres Strait Island status, severe mental illness, the coronary calcium score and chronic kidney disease. So the calculator, as you will have seen on the website, is a sophisticated and comprehensive guidelines for managing cardiovascular disease risk. And so in consultation, we're interested to understand how this might be applied in a more prescriptive way for commercial vehicle drivers, and what the implications are for drivers, licensing authorities and health professionals. And it will help that many of you have been involved in applying it to rail, and to give consideration to how that might work in quite a different and diverse and complex industries such as road transport. So the next area is diabetes. And for diabetes, we certainly understand that the risks for road safety are largely attributed to the treatment of the condition, including the risk of severe hypoglycemia, as well as hypoglycemia unawareness. Although we're also aware that there are cognitive impacts associated with hypoglycemia. So the general approach of identifying people with diabetes may not, on the face of it, have the road safety impacts that might be seen with diagnosing and treating, for example, sleep disorders. However, we also acknowledge that diabetes is associated with cardiovascular disease and sleep disorders, so this is a broader consideration. And we ask you to give consideration to how we integrate all these risk considerations. So for diabetes, a key consideration is the significant rate of undiagnosed diabetes, and it's estimated that 3 in 10 Australians with diabetes are undiagnosed, which has implications for end organ effects that may affect driving, such as vision. The prevalence of overweight and obesity in commercial vehicle drivers is a further point to be considered for this group. As for cardiovascular disease, screening for diabetes risk is not a current feature, and diabetes is identified by self-report through the driver questionnaire. When we looked at the international position, we found that screening for diabetes is also not undertaken in those major jurisdictions, the US, Canada and UK, and identification of diabetes is through self-report. So the rail standard is different in this regard. Whilst it uses self-report in the Rail Transport Worker Questionnaire to identify safety critical workers with diabetes. It also prescribes HbA1c, blood testing for category 1 and urine screening for category 2. And these were options that the working group has been looking at to understand the applicability to commercial vehicle drivers. Also in rail, the diabetes diagnosis is considered in the cardiac risk assessment and the obstructive sleep apnea assessment. In terms of broader population screening, the RACGP recommends, as you would be aware, that risk of diabetes is assessed routinely in the population with people over 40 who do not have specific risk factors for diabetes. And they recommend 3 yearly screening using the AUSD risk assessment tool. So the options for this project have been based on those considerations, looking at either a risk assessment or risk assessment and clinical testing, and we're open to any views about those options. So the next slide, Josie, just shows the diabetes AUSD risk score, which you'd all be familiar with, and that's not included. So our diabetes risk is not included in the rail standard or in any other commercial vehicle standards that we looked at internationally. So that would be quite a change. So finally, with sleep disorders, these are a particular concern in the transport industry, and as Josie mentioned, we're a driver of the current project following the inquest in the ACT, and the interface with fatigue management is also important consideration in that the current heavy vehicle national accreditation standards require that these health assessments are conducted with a particular focus on sleep disorders, although there is no additional guidance as to how this is implemented in practice at this point. We know that these conditions are underdiagnosed in the broader community as well as among commercial vehicle drivers. As Josie mentioned, the Monash Driving Health Study found 13.4% of drivers self-reported OSA. However, there's evidence that the prevalence in the community is substantially higher, with the recent study, Australian study in 2022 identifying 40% of males between 45 and 65 had clinically significant OSA. And the prevalence of overweight and obesity in commercial vehicle drivers further points to this being an issue for commercial vehicle drivers. In terms of what the current approach in AFTD, it doesn't currently prescribe screening for OSA or other sleep disorders. It recommends and includes the Epworth Sleepiness Scale in the forms for commercial vehicle driver assessments. It refers to OSA risk assessment tools such as the Stop Bang Berlin and OSA 50, but it doesn't prescribe any of these, and it doesn't include these in the form. So again, we expect that those risk assessments aren't being routinely conducted. In terms of the approaches in the other jurisdictions, in the US, they've considered the issue of screening for OSA on several occasions, but haven't progressed any changes in that regard. Canada is more proactive, and under their Canadian Council of Motor Transport Administrators National Code, it requires screening of symptoms for OSA and risk factors. They don't prescribe a specific tool, but the symptoms and the risk factors align with the commonly used tools. And the UK's standards largely based on diagnosed conditions. So again, they don't prescribe screening for sleep disorders. As most of you would know, the recently revised rail standard now does include a comprehensive screening and management approach, which has been enabled by recent research pointing to the safety consequences of untreated sleep disorders in the rail system. The rail standard prescribes Stop Bang as the risk assessment tool and retains the Epworth Sleepiness Scale as a measure of excessive daytime sleepiness, acknowledging that that's not always honestly completed. And the standard also provides information about other risk factors to consider. So the standard much more comprehensive now than the previous version of the rail standard, and I think has been considered by the working group in this project as a good basis for a standard for commercial vehicle drivers. Finally, again, we've looked at the public health guidance and but the Red Book and the standards, the guidelines from the Australian Sleep Association don't recommend public screening for OSA in asymptomatic people, but they do acknowledge that driving risk is important and that they recommend appropriate referral for those suspected of OSA and excessive daytime sleepiness, but they don't recommend a practice approach in that regard. So again, just quickly, these are the 3 OSA risk tools that we were looking at. Again, noting that the Stop Bang was the one selected for rail with a cutoff of 3 or more requiring referral for a sleep study. During our working group's discussions, there was a reluctance to land on a cutoff point of 3, acknowledging what the potential impact might be on drivers and the health system. So this is a particular point that we're keen to get feedback on as to how the outcome of this type of assessment might be managed operationally. And that's it from me.
Thanks, Fiona. So throughout our early consultation, we had conversations with lots of other organisations that are responsible for various driver health or heavy vehicle safety initiatives. We turned this into a table, as you can see on the screen here, and identified whether they're focused at national or local levels and what they target across behavioural, technical, environmental or health screening. There's lots of great initiatives underway, but only 2 of these focus on health screening, being Healthy Heads in Trucks and Sheds, which is a national program, and the Open Road program, which is based in Tasmania. We recognise that the changes proposed in our project are not a silver bullet to addressing driver health, and it will require ongoing collaboration along with these current initiatives. As part of the consultation process, we're asking stakeholders whether there are any other initiatives that we're missing, and we'll present a final table to ministers as part of our recommendations. And we welcome your advice on whether there's anything else that should be included for completeness here. So now we've gone through all the current state data, we'll now focus on the options proposed in the paper. As I mentioned at the beginning, the options represent a staged approach and go from option A of no change to option B, improving implementation of current AFTD guidance, to option C, which includes the 3 sub-options. So to make it a bit easier to digest, we've broken it down here. As option A is no change, we won't spend any time looking at this now. So we've got option B and the sub-options for C here. So option B improves current implementation of AFTD guidance in the areas of cardiac and sleep disorders. And that's through building awareness and education with medical practitioners as well as drivers. As there's currently no screening for diabetes in AFTD, it won't be included in this option B. Option B also includes redeveloping the forms to include cardiovascular disease risk questions and a sleep questionnaire like Stop Bang, OSA 50 or Berlin, as Fiona just mentioned. These are already referenced in the text, but they haven't been translated across to the forms. These updates could be considered interim measures and could happen pretty quickly. Option B builds upon option C and includes 3 sub-options to target the 3 different health areas. Option 1C relates to cardiac risk and proposes that AFTD be amended to prescribe cardiovascular risk assessments for commercial vehicle drivers. Update guidance on assessing and managing cardiac risk for commercial vehicle drivers. This would be new text that would be drafted with input from our cardiac working group members. Include more detail on the cardiac risk calculator, which was updated in 2023, and updating the forms, as I mentioned in option B. Option 2C relates to diabetes and proposes that AFTD be amended to apply the OSD risk every 5 years, and in addition or in replacement of this, also require a routine non-fasting blood test for HbA1c every 5 years, plus the updated guidance for commercial vehicle drivers and updates to forms previously mentioned. Option 3C relates to sleep disorders and proposes that AFTD be amended to prescribe OSA risk assessment using a preferred tool, include more comprehensive guidance for assessing risk, testing, interpreting results and management of OSA, including the preferred questionnaire. And I'd like to note that we haven't included the details around threshold for testing, but are keen to hear your views. There were also suggestions around including some more content about fatigue management and the role of fatigue monitoring technology. We're keen to understand your current experience in these areas, whether you're already doing this screening, and if so, what your approach has been. We know that there's a fine line between introducing new screening and overburdening the driver and the health system. There will also need to be considerations about how to operationalise any new screening requirements, and we'll now go into the benefits, costs and limitations. So the discussion paper has quite a lot of detail. It's hard to condense it into a single slide, but here are the key details. We've also included a disclaimer to state that the potential costs and benefits are more likely to be realised in jurisdictions and industries where there are periodic assessment requirements. So for option A, we've noted that there'll be no further benefits and that maintaining the current state may actually pose risks for the health of drivers when we have data to support the fact that the industry is at an increased risk of CVD, diabetes and sleep disorders. In terms of benefits, it's likely that options B and C will result in improved confidence, quality and consistency in conducting health assessments, as doctors will have clearer forms to follow and new content with clinical considerations. The health benefits of early identification and management of risk factors and chronic conditions, such as cardiac, diabetes and sleep disorders, should also lead to improved road safety outcomes. In turn, due to these conditions being picked up early, it should reduce the ongoing impact on the health system. In terms of costs, we've highlighted that the increased costs will be around implementation, including communication and education activities. There will be increased costs for drivers and employers for pathology testing, counselling and referral, and time off work for tests. If a driver is found to have a condition, there will be a cost imposed to manage their condition or other risk factors. There may be potential impacts on workforces while drivers are undergoing investigation and treatment. and this might also impose a burden on the health system with an influx in referrals and tests. There'll also be costs for driver licensing authorities to action the system changes, as well as increasing the number of conditional licenses and the reviews that go with this. There are still many policy questions to resolve around things like how periodic testing will work to ensure that drivers are only having the screening performed as part of the frequency outlined in AFTD. Would a medical review for a separate condition trigger the medical professional to screen for these 3 conditions? And there are also some legacy issues to be considered around the relationship of AFTD assessment and information being shared with a driver's GP if they have one. So next steps, we're really interested to understand your views on how things currently work and how you envisage new screening tools to be operationalised in your practice. We welcome written submissions with your thoughts on the costs, benefits and limitations of these options, plus anything else that you think we've missed or could be an alternative approach. Submissions can be made on the NTC website and close on Friday the 9th of May. After the consultation closes, we'll review all of our submission material and prepare a consultation report and recommendations for consideration by Transport Ministers. We expect a decision later this year, which will inform our next review of AFTD. Please reach out if you'd like to discuss anything in the lead up to making a submission.